This Git7 colon. The first slide will showing the small intestine on the right and the colon on the left, and this is the stomach going this way. This is called non-rotation, and the problem here is internal herniation. This one showing the rectum, sigmoid, and this directed to the right, and the appendix is here seen. So this direction of the sigmoid to the other side, to the right, is due to incomplete rotation and malfixation of the colon. The problem again is herniation, internal herniation, and the other problem is the dolichocolon. You can see going into the pelvis, symptomatizing usually by distension and dyspepsia. Here we get what we call reversal rotation or reversed rotation. So the colon may be seen behind the duodenal loop, behind the superior mesenteric, or behind the kidney, and this is called retrorenal colon. In infancy, you will find this pattern of colon sometimes, and this is called the normal ahostral colon in infancy. Normal ahostral colon in infancy. This is very rare to find such an appearance with a tube is filling parallel to the colon, and this is called colonic duplication. In infancy again, but also in adults with suppressed immunity, you might find air in the wall of the colon, and this is called pneumatosis coli. Pneumatosis coli. It is a sign of severe or high risk infection. Now, multiple colonic filling defects. These are either polyps, single or multiple, and lymphoma. Look to this. You find that there are multiple small filling defects along the outline, and these are myriads. There are multiple filling defects are seen. Almost are of the same size. This is an example for familial polyposis. Now, what are the causes of smooth colonic stricture? Could be, of course, ulcerative colitis, Crohn's disease, radiation, ischemia. Ulcerative colitis, we know that the end stage of ulcerative colitis is pipe stem appearance, and we know that the end stage of inflammatory Crohn's disease will end by stricture formations, and radiation, of course, will cause stricture. Ischemia can cause healing with stricture formation. Here is an example for multiple strictures here and there in asymptomatic, in ahostral colon, the colon showing no hostra, and this is the appearance of the ulcerative colitis strictures. Smooth colon means without hostra. Of course, the main reason is the ulcerative colitis. The second is post-ischemia and post-radiation. The word cathartic colon means the colon which is not doing any effort to expel fecal material. That means it is under effect of purgation, and the prolonged use of laxatives and purgatives cause this type of colon, which is of no hostra. It's called smooth colon. So the main reason is the ulcerative colitis, as in this case. Remember that we are putting ulcerative colitis plus ischemia plus radiation and the end stage of Crohn's in one basket. Now, ileocecal disease, what's called as coned cecum, and the presence of filling defects at the region of the cecum could be due to, of course, Crohn's, lymphoma, and TB. This is the three main, but include also cancer and carcinoid. If appendicitis and with mucocele formation, or if appendicitis or mucocele, and if there is ileocolic intussusception, you might find the filling defects or coned cecum or abnormal ileocecal junction. So abnormal ileocecal junction could be due to inflammatory process as in TB and Crohn's, could be due to malignant process like lymphoma and cancer, and could be due to something related to the appendix, appendicitis or mucocele, and finally ileocecal disease could be due to ileocecal intussusception. To repeat again, coned cecum or abnormal ileocecal junction could be due to inflammation as in Crohn's and TB, lymphoma and cancer as malignant processes, and appendicitis and mucocele in one hand, and ileocecal intussusception may be the reason for ileocecal disease. This is the appearance of the abnormal ileocecal junction. It is abnormal in the following items. Number one, the decreased capacity. Number two, the irregular bossy outline on both sides. And number three is the 90-degree entrance of the ileum into the cecum. Now, if you collect this data with this appearance and the normal barium here, this is typical for TB. And TB of the ileocecal junction could be atrophic or hypertrophic. Atrophic means that healing process occur. Hypertrophic means that granuloma are there, and both hypertrophic TB and atrophic TB can be reduced such an appearance because we are filling the lumen and we are not seeing the outline. The outline can be seen in CT. So the entrance of the ileum into the cecum in 90-degree or reversed angle, it should be an acute angle. This suggests that there are some nodes here, or there is some cicatrization or abnormal masses pushing that ileum up. So this is one. Number two is the decreased or diminished capacity of the cecum and ascending part of the adjoining the ascending colon, and the multiple filling defects seen. The appearance in this way is usually of lymphoma, usually of TB. The appearance is usually due to TB ileocecal junction. And as we said, we have hypertrophic type and atrophic type, and to differentiate both we should see the thickness of the soft tissue around, and this is only seen in CT or operatively. Here we have another coned cecum. Ileum is going and the ileum appears normal and the colon above appears normal. This excludes tuberculous process. The appendix is filling well, and there is something encroaching on the cecum, diminishing its capacity, it could be malignancy or lymphomatous infiltration of the wall here, because this part appear normal, this part is normal, and that part is normal, but the abnormal part is this shouldering here, this area. So malignancy of the cecum should be considered in such a case. If we find double tracking of the colon along the wall, the first possibility is Crohn's, second is diverticulitis or diverticulum with perforation and infection, and adenocarcinoma. So in this sequence, Crohn's, diverticulitis, and adenocarcinoma are the three main causes for double track colon. And this is the appearance of double tracking. It could be due to, as we said, Crohn's, it could be due to diverticulitis, and it could be due to malignancy. In such case, it is a Crohn's disease, because in Crohn's usually there are some submucosal perforations. If you find a widened presacral space, the first possibility is that the colon is diminished in size, as in ulcerative colitis, or the content of the pelvis are big, as in pelvic lipomatosis. Again, if there is a mass, rectal or sacral, and finally, but less frequently, in Crohn's disease. So the first four are the more applicable. The first one is the most common, it's ulcerative colitis. Number two is pelvic lipomatosis, and number 3 and 4 rectal or sacral tumors. Of course, we should include radiation also. This is the appearance in ulcerative colitis, in which we can find this space is too big. Normally this space is no longer than 2 to 3 millimeter, but here it reaches 1.5 or more centimeter, or 2 centimeter, and the resultant this results from the small caliber of the colon. The colon, the rectum is not distended. There is no distensibility of the rectum because of the ulcerative colitis. Here we have a stricture, and here we have a stricture, and it is very difficult to differentiate inflammatory strictures from malignant strictures, except if there is a chance to see the mucosa, as in here. But this appearance could be due to shouldering of malignancy, and this appearance could be due to shouldering of malignancy. So it is very difficult to distinguish malignant strictures from inflammatory strictures of the colon. There is definite nerving in this area. In this area, there is definite nerving, and this is due to the anastomotic site after resection of a tumor. So post-operative stricture is common. And here there is definite nerving, but the nerving is not due to inflammation or due to malignancy. It is due to volvulus of the sigmoid colon, volvulus of the sigmoid, and this is the tube inside, usually deflates. The volvulus of the sigmoid usually deflates, but of course it will recur, so the treatment should be fixation operatively. Here in this one we have this is the rectum, sigmoid, and this is the left side of the colon, and then part of the transverse of the colon. The transverse colon is the seat of multiple thumb printing, as if somebody is pressing on the transverse colon was by his hand, resulting in these defects. We call it thumb printing. Thumb printing of the colon is characteristic of submucosal hemorrhage or hemangioma, especially if it is involving a long segment, because if you find this appearance in a short segment, you should put malignancy first. But a long segment of stricture with some printing is either due to hemangioma or hemorrhage. Now this, if this is the sigmoid and this is the ascending and this is the splenic, descending and this is the splenic and this is the transverse colon, you find that there is some impression here of a smooth outline and it is extending inside here, and this is the ileocolic intersusception, small intestine within the colon, small intestine with the cross-hatching mucosa within the region of the sigmoid and this ascending colon. This is called ileocolic intersusception. This is another ileocolic intersusception in which we find the small intestine within the colon, and here it forms as if a concertina pattern, which is characteristic for the intersusception. This case is showing a rectum with a vaginal fistula, and the contrast is going into the vagina. Such an appearance could be occurring as birth trauma. Again, this is the ascending colon with the haustral pattern, and this is the cecum, and there is definite non-filling of this area of the cecum. This area is the region where the appendix should come out. So we could not say that this is typically of malignant process or tumor of the cecum, but it could be due to appendicular disease. And now we have the advantage of doing CT abdomen, which can reveal the if there is an inflammatory reaction around, with the typical appearance of the appendicitis or appendicular abscess or mucocele. So in these cases it is appendicitis. Now again, similar appearance. We have some defect along the medial aspect of the cecum, and the ileum is not visualized, but there is no definite irregularity. There is impression, there is some indentation. In the CT, we have these inflammatory reactions. The peritoneal fat is traversed with strandy fat, and of course this is due to chronic appendicitis. In Crohn's disease, we have the typical changes of skip lesions. Part is involved and part is not. Part is not involved and part is not involved. Number 2 is the deep rose thorn ulcers, and it can affect any part. But in such a case, we should first put the possibility of diverticular disease, and diverticular disease is usually seen as first as a spasm with filling of the neck of the diverticuli, which is spiky, and here there is some contrast outside the lumen, maybe due to diverticulitis, but this case proved to be Crohn's. So take care that Crohn's can occur at any part of the gut. It's not only diverticular disease, but also Crohn's can affect the sigmoid. Skin lesions, deep rose thorn ulcers, and the asymmetry. One side is involved, one side is not. Part is involved, part is not. And the presence of submucosal leakage or submucosal double track sign here and there. All of this can be due to Crohn's, but in the differential diagnosis at this region exactly, with these serrations, it should be diverticulosis should be considered with spasm and diverticulitis also. Here we have some polyps, and polyps of the colon will appear as something defective delineated with barium, rounded filling defects delineated with barium. In this one you will find a lot of polypi, lot of filling defects rounded here and there, and they are affecting most of the colon, like this one here, and this is colonic polyposis. Of course, bilharzia polyposis is something similar, but it is of variable size. It's not of the same size as here, and it might grow up to be large masses encroaching on the lumen. This is first. The second thing is that in bilharziasis we have what we call pericolonic fibrosis, and the rectum will be narrowed because of the pericolonic fibrosis. Fibrosis around will make this lumen narrowed and full of such things, such variable sized filling defects. But in this case, this is familial colonic polyposis. This is an example of the start of the ulcerative colitis of the colon, where we have the spiky outline, the haziness of the wall, and the double tracking. This is an active process of ulcerative colitis. Ulcers like this one, like that one. These are not hostulas. These are some are hostula and most are ulcers. And the double tracking here is very evident of the lumen, and the hazy L definition is due to the edema. This is early ulcerative colitis of the colon. Healing process will result in a tubular bi-stem colon of late ulcerative colitis with loss of the hostular pattern. Mind you that the hostular pattern may be lost on the left side, may be not seen on the left side in normal subjects, but we are concerned with the transverse and the ascending colon. We might see the serrations of superficial ulcers, and being narrowed, expect that you can find the prerectal space wide in lateral view. So any case of barium enema is better to be completed with a lateral film for the rectum. This is another case of ulcerative colitis with multiple strictures here and there, smooth long strictures with the small ulcerations along the wall of the colon, with loss of the hostular pattern and decreased length due to fibrosis compared to the other things here, and the rectum is narrowed. Expect the prerectal space is wide. This is ulcerative colitis. In diverticular disease of colon, we might get scattered diverticuli, and these are usual in old age to find some scattered divertically like that. But if they are extensive, see here there are multiple barium filled neck, and here are the divertically, the neck of divertically are filled. The sigmoid is thrown into spasm. There is a spasm of the sigmoid colon. Compare this lumen with that lumen. There is definite narrowing here. This is due to spasm, and the process is involving most of the colon and the barium filled protrusions, either neck or through diverticulum is filled. Now this is diverticulum disease. Diverticular disease can start with sawtoothing and filling of diverticuli, or spasm, or double tracking due to leakage, or peridiverticular abscess formation, fluid collection around the sigmoid, which may extend to fill into the left iliac fossa to form a big pelvic abscess. And finally, you should consider that in diverticular disease, as in Crohn's disease, malignancy can complicate such areas. Malignancy can complicate such areas. Here you can see the sawtoothing due to and the spasm. Of course, there is a spasm, and here the filled diverticulum. Sawtoothing and the spasm. Compare this one with this one. There is definite spasm of this area, and there is a peridiverticular abscess here. There is something filling with contrast related to the neck of one of the diverticulus. This is a peridiverticular abscess. So we have the sawtoothing, the spasm, the diverticular filling, and the peridiverticular abscess, small or it may be large, filling the pelvis. And finally we can get malignant change. And don't forget that this spasm in itself is something which will bring the patient to consultation. We have small intestine, but the small intestine here is displaced with this low density area, globular area, which is a renal cyst. So this is just to show that masses can displace. So can you consider this as a renal cyst? Of course, it could be anything. There is a definite mass here displaying the transverse colon up, and the small intestine and the other parts of the colon down and anteriorly. And the nature of such a thing should be correlated with CT. In old days, when there was no CT, such an appearance could localize a pancreatic pseudocyst, for example, because of the smooth outline of the mass. But if you consider retroperitoneal masses, you can put aortic aneurysm and lymphosarcoma and leiomyosarcoma of the small intestine, and of course muscle tumors from behind, retroperitoneal masses, all can produce such an appearance. But the smooth pattern of the displacement suggests that this is something cystic, and usually this is a pseudocyst of the pancreas. If smaller than this, it can be due to lymph node enlargement. Now here we find that if you follow the contour of the abdomen, you will find that there is some contrast filled viscous outside the contour of the abdomen, and this is if you consider a post-operative break here, like post-nephrectomy, the colon may bulge and herniate. This is a post-nephrectomy colonic herniation. Here we can see that the outline of the colonic segments is well seen from behind, from inside and from outside. That means that it is limited by air from in and out, and this denotes pneumoperitoneum. An erect film will solve a problem. This is rectum and this is the sigmoid, and we find that there are irregular outline here, and if we go into the history, irregular outline with bleeding per rectum should be considered malignant till otherwise proved, but irregular outline with bleeding every month with the menstruation in a middle-aged female should raise the possibility of rectal endometriosis. Now here we have the apple core appearance with shouldering on either side and a fine tract in between. This is adenocarcinoma, and there is another adenocarcinoma at this region, sigmoid, and then descending, and this is the seat of another tumor here with dilatation behind. Colonic adenocarcinoma, the most common region is the sigmoid region. Here is another, and the sigmoid with the irregular track, short segment of nerving, apple core appearance, shouldering there and here with irregularity. This is typical of carcinoma. Irregularity means carcinoma, and here we have the cecum with ill-defined filling defect on that side with again nerving here, and there is another filling defect here. So this is a carcinoma of the cecum. Short segment of nerving with irregularity, irregular track, irregular lumen, shouldering are the criteria to diagnose adenocarcinoma. Here another short segment of nerving with irregular lumen, shouldering, and this is of course a reconstruction CT for a carcinoma causing obstruction. We have irregularity at this region, and we have another irregularity at this region and nerving. These are double adenocarcinoma which can occur. Of course rare, but it can occur. This is the rectum with this irregular area, irregular mass with ulcerations. Barium is seeping in between the necrotic mass here. This is irregular necrotic mass, and this is a distal rectal carcinoma. In this one we have some divertically here, but the problem is not there. It is in the region of the non-distensible rectum in this region. It's ileum, and the ileum is going to the cecum, and the cecum is the seat of filling defect with non-filling of the cecum. The cecum should fill in this area. This is tapering nerving of short segment and with multiple indentations, usually due to lymph nodes at this region. It's cancer cecum. This is a rectum, sigmoid, and there is cancer somewhere here, but the malignant process resulted in perforation and abscess formation. Malignancy should not only considered from the colon, but it can be due to invasive lesions from outside, as in this case. If you look at the air of the gas outlined stomach, you will find irregular indentations, and there is definitely a soft tissue shadow between the indented colon here and the gas shadow inside, and this is due to gastric carcinoma. So this is a gastric carcinoma which is indenting and invading the mucosa of the colon, causing definite narrowing and causing the mucosal infiltration, submucosal infiltration due to the mass nearby. The reverse can occur. A colonic carcinoma can invade the stomach in such an appearance with irregular outline of the wall. So malignancy of the colon can invade the surrounding. Malignancy of the surroundings can invade the colon, and it should be considered in all cases. For example, this is a pancreatic. This is proved pancreatic carcinoma, and here it is invading the colon. Notice that in invasion, usually you have starting indentation and then irregular outline if it is truly infiltrated. In this film, we have part of the transverse colon with anastomosis, ileocolonic anastomosis, and at the side of the anastomosis there is definite soft tissue inside, and there is definite soft tissue indentation here, displacing the gases of the small intestine away. So there is a mass in this area. So this is an anastomotic recurrence of carcinoma. The criteria to judge on this is the fixity, the irregularity, and the intraluminal mass with the indentation with the extraluminal mass. So please consider fixity, irregularity, intraluminal and extraluminal indentations. These are the criteria to diagnose a mass within the loops. Here there is definite displacement of the sigmoid from the pelvis, but the displaced sigmoid from the pelvis is definitely irregular and stretched, and the lumen is narrowed. So what a mass can be reduced such a thing in the pelvis of a female? It is usually a fibroid, and if the fibroid changes into something malignant, it will invade and do such an appearance. Here is an ovary with mass indenting that part of the colon. So if we want to put criteria how this can be diagnosed, it is not genuine malignancy of the sigmoid. First, due to displacement or indentation. Second, due to the irregular outline. So here we can definitely say that this part should go down and go up like that. It is definitely displaced, definitely indented, and at the same time it is irregularly narrowed. So displacement, indentation, and irregular narrowing with intraluminal growth, and soft tissue tumefaction devoid of gas shadows around, denote that there is a big mass around, causing such an appearance. similar one with colon showing multiple divertically, but definitely there is a mass here. This mass could be from a malignant transformation of in chronic disease, chronic diverticular disease, or it could be due to an indentation from a pelvic malignant mass with infiltration of the colon. Both can do. So please consider that not all malignancy or malignant characters shown in the colon could be from the colon. It could also arise from the surrounding invading the colon. We have here increased retrorectal space, and we can say that increased retrorectal space is usually with ulcerative colitis, but there is no ulcerative colitis here, as you can follow the HOSTRA of the colon. The HOSTRA of the colon excludes ulcerative colitis at this area, but number one, ulcerative colitis can involve only distal colon without involvement of the rest of the colon, first. Second, but if you know the clinical situation that this patient has a prostatic malignancy, you can imagine that malignancy can fill this space by invasion. So a prostatic cancer can grow and result in very big masses, which can obliterate the lumen of the rectum and sigmoid, or displace it from the sacrum and causing increased retrorectal space. Prostatic carcinoma can do such an appearances: invasion of the rectosigmoid region, invasion with nerving and compression on the rectosigmoid region. As we said, that the colon could be invaded by many things. A pancreatic tumor can invade, gastric tumor can invade, ovarian tumor can invade, fibroid can displace and indent, and if malignant it will invade, prostatic deposits can invade, and a renal cell carcinoma can also invade. So invasion of the colon, as any of the intestinal loops, could result from nearby malignancy. Now, not only direct invasion, but also seedling. So metastasis seeding in the pelvis can result in such an indentation on the on the rectosigmoid junction. Here we have of course, as we said, there is definite change of the caliber. There is some changing of the lumen here, and there is soft tissue displacing the intestinal loops, and as we said, fixity, irregularity, intraluminal and extraluminal evidence of mass should raise the possibility of something involving the colonic mesentery. Here, cancer colon spreading into the mesentery and causing such an appearance. These are deposits coming from above, from gastric fundus, and if you remember that gastric carcinoma can produce pelvic deposits by seedling. Of course, it can invade the sigmoid. It can be result lastly in such an appearance. To summarize this, it is a fixed irregularity with intraluminal masses or intraluminal filling defects and irregularity, and something in between and there is something in between denoting the displacement of this away from this. So there is a extra luminal mass here. This is a typical example of invading subserosal deposits. Rectum is narrowed due to surrounding deposits from breast cancer. So we can say that the rectum can be displaced from the sacrum in case of ulcerative colitis, in case of radiation, in case of deposits and pelvic masses. Rectal tumors, sacral tumors, as we said, and rectal tumors are maybe starting from the rectum or maybe starting from a surrounding. An abscess can result in some changes in the nearby colon, as the case in pancreatitis and cholecystitis. A perinephric abscess can result in edema of the mucosa or displacement of the mucosa, with, in such case, the right kidney is not excreting, and it forms a large soft tissue tumefaction due to infection, perinephric abscess. The mucosal edema can result in some colonic changes in case of cholecystitis. So cholecystitis, pancreatitis, and perinephric abscess can result in such colonic changes. Here, the pancreatic infection or acute pancreatitis can affect the transverse, resulting in spacing of the mucosa. Spacing means that there is thickening of the mucosa, and thickening of the mucosa, as we know, that can be either due to submucosal edema, submucosal infiltration, or submucosal invasion. Here, the similarity and homogeneity of the thickness is due to simple submucosal edema and not malignant process or infiltration. Similar changes are here. These are the thickened mucosa seen as a response to a nearby pancreatitis. The changes here are more aggressive, and the sigmoid is showing some spasm, but again it is the mucosa which is markedly thickened. This is the mucosa bulging into the lumen, mucosa bulging into the lumen, and so on. There is some similarity. So, and the long segment of involvement, this is usually due to nearby infection, as in this case it was a pancreatitis. Similar changes in pancreatitis can result in chronic mucosal edema, thickening of the mucosa. Now suppose that there is an inflammatory process which resolves, it will cause some traction or some fibrosis, which can result in simple stricture of the colon. Stricture of the colon can be due to radiation, can be due to post-inflammatory, can be due to malignant process, and of course the first two possibilities are the ulcerative colitis and Crohn's disease. Here we can see that the rectosigmoid is definitely converted into very narrow canal due to soft tissue mass here displacing the gastrus up, and this is due to pelvic mass. An abscess can do the same. Pelvic mass, pelvic abscess, pelvic hematoma, all can result in such an appearance. Thank you.